All right, let's jump right in. We're going to be talking about one of our most important responsibilities, assisting residents with the self-administration of their medication. We're going to break down exactly how to do this the whole way. That means with precision, with safety, and with that person-centered approach that really defines everything we do here. So, here's what we're going to cover. First, we'll get into why this is just so critical. Then, we'll talk about your foundation for safety, the tools you'll use. After that, we'll walk through this step-by-step medication checklist. Then we'll tackle some real-life scenarios. And finally, we'll talk about our ongoing commitment to practice.
First up, why does this matter so much? Let's really dig into the bedrock of why we approach medication support the way we do.
Okay, this is probably the most important thing to get right. We assist, we do not administer. What does that mean? It means we are a support system, helping residents take their own medication. This is all about respecting their autonomy, their right to choose, and their right to refuse. It's right there in Title 22. We never, ever force someone, and we absolutely never hide medication in their food. That's a line we just don't cross.
So let's talk about what's at stake. And first and foremost, it's about the resident. A single medication error can have direct, serious consequences for their health. And beyond the physical harm, it can completely shatter the trust they place in us every single day. That trust is everything.
And look, these aren't just small mistakes. For our home, procedural errors create huge legal and licensing risks. A single citation can threaten the stability of our entire program and our ability to care for everyone who depends on us. The stakes are incredibly high.
And this comes down to you, personally. As a direct support professional, you are accountable for following this procedure to the letter. Any errors will lead to corrective action, and that can include termination. The bottom line is this: getting this right every single time is a fundamental part of your job.
All right, now that we know why this is so critical, let's get into the tools and the core principles you're going to use to ensure safety and accuracy every single time. These 7 rights, you need to know them by heart. They are your non-negotiable mental checklist. Before every single medication pass, you are running through this list in your head. Is this the right person, right medication, right dose, time, route, reason, and is the documentation right? There are no shortcuts, and there are no exceptions, ever. Now, your guide through this whole process is the MAR, the Medication Administration Record. I want you to think of this as your source of truth. It is a legal document, and it has the doctor's exact orders. You have to verify every single medication against it. And if the label on the bottle does not match the MAR exactly, you stop. You just stop the process and get an administrator. No guessing. We also have the centrally stored medication and destruction log. This is all about accountability. It's how we track every controlled medication from the second it comes into our home to the second it's either taken or properly destroyed. And remember this key rule: destroying medication is a 2-person job. It always requires 2 staff members to witness and sign that log together. Okay, so we've got the tools. Now let's walk through the actual step-by-step operational checklist you'll be using. This whole process is designed to be systematic, safe, and just reflexive. The process breaks down into 4 main steps: verification, preparation, presentation, and documentation. But I want you to notice something really important here. Within those steps, there are 3, count them, 3 distinct checks against the MAR. This triple check system is our built-in safety net. It's designed to catch any potential errors before they can happen. Before we go any further, I want you to really let this sink in. This is a core WHO principle. Choice is not a delay. It is the service. Our goal isn't just to get a task done as fast as possible. Our goal is to preserve a resident's autonomy and their choice. This idea is woven directly into how we do things. So here's where that choice is the service idea really comes to life. During the preparation step, you'll do your second check. That means reading the medication label out loud while you're comparing it to the MAR. And right then, at that exact moment, you offer a choice. Something simple like, hey, would you like to take your medication now, or would you rather wait 10 minutes? Then you place the medication into a cup, making sure your hands never touch it. That's about both dignity and hygiene. Okay, step 3, presentation. You're now right there with the resident. This is where you do your third and final check of the medication against the MAR. Then you're going to state the 7 rights out loud. So you'd say something like, Neil, here is your lisinopril, 10 milligrams to be taken by mouth now for your blood pressure.
Then you hand them the cup and the water and you watch them take it. This is it, our final safety gate.
And I can't stress this enough. Documentation is not something you do at the end of your shift. It happens immediately after you've watched the resident take their medication. You initial the MAR for each one. And if it's a PRN or as-needed med, you've got one more step. After the required time has passed, you have to follow up, ask them how they're feeling, and log the response in the PRN log.
Okay, so we've got the procedure down on paper, but what does it look like in the real world? Because let's be honest, our work isn't just about following a checklist. It's about navigating these complex human moments using the whole philosophy. This slide just says it all, doesn't it? When a resident refuses medication, the typical response is a command. You have to take this. But that's not our way. The way is collaborative. We see that no, not as defiance, but as communication. It's a signal. So we get curious. We ask questions. We offer to try again later. We shift it from a power struggle to a partnership. This is such a powerful thing to remember, especially in those tense moments. When you're with a resident who is emotionally dysregulated, your own internal state, your calm or your stress, it enters the room before you even say a word. Your calm can create safety. Your anxiety can pour gasoline on the fire. So, what do you do when you're faced with that dysregulation? Well, your first job isn't to fix them, it's to regulate yourself. Take a deep breath, center yourself. Then you approach with calm curiosity, not judgment. You maintain consistent boundaries, of course, but you offer grace. And please remember, it is always okay to postpone the task. Connection and safety always come before the checklist. Finally, let's talk about how we maintain these critical skills. Because this isn't a one-and-done training. This is an ongoing professional commitment. Title 17 is very clear about this. Medication assistance is considered a core competency, and it requires dedicated training time. But it's more than just the initial session. It requires constant, ongoing practice to stay proficient. And that's exactly why all DSPs are expected to practice and log medication pass scenarios every single week. We do this even if none of our current residents require medication support. Why? Because this is about building muscle memory. It's about making this skill so sharp, so reflexive that it becomes second nature. And let's end here with the question that should guide everything we do. After every interaction, and especially after helping with medication, I want you to ask yourself this. Not just, did I follow the steps, but how did the resident experience this moment? If the answer honors their dignity, their autonomy, and their feeling of safety, then you know you're truly practicing the WHO way.